Okay, well, I apologize that we're getting going here a little bit late, so I appreciate you all waiting around to get started here. All right, so today we're talking about hemorrhoid artery embolization, a minimally invasive treatment for internal bleeding hemorrhoids. And hopefully this will be something that'll be useful for you to know, and maybe something that could help with problems that you're having. Just a little bit about me, in case you haven't been on a webinar with me before. I trained at the University of Southern California and then at the University of North Carolina. So I went from USC to UNC. I was also in the Navy for a period of time in between that. And I did my residency at UNC in radiology, and then my fellowship in interventional radiology. And now I work at IR Centers, which is located in Briar Creek in Raleigh. And the reason you received this email to promote this is because you are a patient at the Associated Urologists of North Carolina, and that is who owns the clinic that I work at. So that's the connection. All right. All right, so let's talk a little bit about hemorrhoids. Hemorrhoids, when we talk about them, we automatically think of tissue that may be protruding out of our anus or little veins that are bumpy on the outside of the anus. But the truth is everybody has that tissue. It's just a matter of whether it's pathologic or whether it's abnormal for people. And so the problem happens when they become swollen and inflamed. That's when it becomes symptomatic. And ultimately, if you've had hemorrhoids, bleeding is a big one, and then just itchiness. Occasionally, it can interfere with the ability to have a bowel movement or to get the stool out correctly. So that's all obviously irritating. So what causes hemorrhoids? Well, the biggest thing is increased pressure. So that's why pregnancy is a big one, especially during labor when you're delivering a baby. All the pushing and stuff can cause those veins to become engorged and irritated. But other things as well, being chronically constipated. So if you're constantly straining on the toilet to have a bowel movement, that also can cause hemorrhoids. Then we have some other things that are a little bit different, like liver disease or cirrhosis that can cause you to have hemorrhoids. Or if you're similar to, I guess, delivering a baby, if you're a power lifter and you're lifting huge weights and really pushing with your abdomen while you're doing that, that can also cause you to have the hemorrhoids. Additionally, it's also associated with obesity, and it's associated with a low fiber diet, and that's mainly because of the constipation piece. And then also pelvic floor dysfunction. All right, so let's get a little bit into the anatomy here. So when we're talking about, there's actually two types of hemorrhoids. There's internal hemorrhoids and external hemorrhoids. So the internal hemorrhoids are these guys that we're seeing kind of further up. And what they tend to do is get swollen and engorged and then droop down. And if they droop down enough, they'll actually protrude out of the anus. And so we call that prolapse when that happens. And depending on how big they are, either they might just pop down occasionally and then pop back up by themselves, or sometimes someone, yourself or a physician, can actually push them back in, or sometimes they actually get stuck where they can't go back in. So there's all different levels of prolapsed hemorrhoids. As far as the symptoms, when you have internal, the most common one is bleeding. They can be painful, but it's much more common that they just bleed. And that blood may happen when you have a bowel movement, or it may just happen when you wipe yourself and you see it on the toilet paper. External hemorrhoids happen out on the skin here, and they're a little bit different. They tend to be itchier. They can also get painful if they thrombose, get clotted. And that's the kind of thing that you would use preparation H or take a sitz bath or something like that would be soothing for those type of hemorrhoids. All right, now treatment options. So we're going to talk mainly, this is about internal. What do you do for internal hemorrhoids? Well, if you go, the first step would be just to do lifestyle changes. So are you chronically constipated? Are you straining too much on the toilet? These are things that you can change by changing your diet, changing just, it's also associated with how long you sit on the toilet. So if you're sitting, having a bowel movement and you're on your phone or you're reading a magazine or whatever, and you're there for 30 minutes or so, that can be a risk factor for hemorrhoids. So the first step is to make those changes, do the things that are easy. if that doesn't work, the next step is when you go and see your gastroenterologist, most likely what they're going to, sorry, you can't hear me. Well, I'll speak up a little bit, but I think it might be your computer. The thing that's they're most likely going to do is called rubber band ligation. And that's where they insert a small device up and through the anus, and they basically catch the hemorrhoid and put a rubber band around the lower part of it and strangulate it. And that causes it eventually to fall off. So that's probably the most common procedure that's done in office by gastroenterologists. There's a secondary one called infrared radiation, which also uses kind of a laser to treat the hemorrhoids. Minimally invasive radiation, minimally invasive procedures, another procedure with a laser, or what we do, which is hemorrhoid artery embolization. And then finally, there's a surgery that you can do that, when you ask the surgeons, they'll say it's painful for the patients, and it's also painful for them. They're not crazy about it, but sometimes it's the only resort is to have a hemorrhoidectomy. Okay. So let's get into what is hemorrhoid artery embolization, or HAE. So most of the procedures that I do are inside either the arteries or the veins. That's just what my specialty does. And so what this procedure does is we go through the arteries and we find the arteries that are feeding blood to those engorged veins, and we block those arteries off so that the blood doesn't engorge the veins anymore. And that's how we treat the hemorrhoids. And we know this works because there was previously surgeons would go in and do ligations, meaning they would tie off the same arteries, and that worked. And so we're doing this without having to cut people open. All we're doing is putting a little small catheter into an artery. So it's a very small hole that we make. A lot of people say, well, if you're blocking the arteries to the hemorrhoids, how does the rectum continue to receive blood? Does it also starve of blood, and can that be a problem? The truth is there's a lot of redundancy in the arterial supply to that area. So even though we're blocking the main arteries to the hemorrhoids, the actual rectal tissue, the wall of the rectum and all that is still receiving blood through other means. All right, so if you were to come for one of these procedures, this is how it would work. So the first thing is you come in the office and we would offer some Valium, a medication to just relax you. Now, it's not a painful procedure. That's what's great about this procedure, and especially when you compare it to the rubber band ligation. This is not, it really, you don't feel much of anything during this procedure. So the medication is not for pain. It's just to allow you to relax in case you're nervous about what's going on. We then put a very tiny catheter about the width of a piece of spaghetti into the artery in the groin area, in the femoral artery. And then using X-ray, I'll guide that catheter through the arteries until I get to the branches that supply blood to those hemorrhoids. And once we're there, we put in two things. One is these little tiny microparticles, little spheres, and then also coils. And the reason we do both is there's research that has been shown that using one or the other is not as effective as using both together. And so we have that data to go off. So we use both together to get the best possible outcome. The procedure is pretty quick. It usually takes anywhere between a half an hour and an hour. And then afterwards, there's a 90-minute recovery. All right, so let's get the video going here. So I'll narrate as we go. So the first thing is we puncture into that artery right in the thigh. Again, it's just a little hole like getting an IV started. And then we run this catheter up into what's called the inferior mesenteric artery, which is what you're seeing there, and down into the superior rectal arteries. And once we're in that location, we find the arteries that are supplying blood to the hemorrhoids, and we inject those little particles and those coils. So that's a little hemorrhoid there, and here we are putting actually the hemorrhoid's at the bottom. That's the artery going to the hemorrhoid, and we're blocking that off. And you can see, I don't know if you can see it, but there's a little coil there. That's the coil right there, and that's causing less blood, and the hemorrhoid then shrinks down. All right, so back to the slides here. Good. All right. So afterwards, well, like I said, you'll lie flat for 90 minutes. We're going to say no heavy lifting for 3 days. There really are very few symptoms after this procedure. Unlike, I don't know if you're familiar with the prostate artery embolization that we do, there are some symptoms after that. But this, people don't feel much of anything the next day. It's important to know that the hemorrhoids may not stop bleeding immediately. So they may continue to bleed for a few days after that. And once in a while, we need to bring patients back to do a second embolization, although it's pretty rare. The procedure is covered by insurance, so there's no issues there. And it's a pretty painless way to treat hemorrhoids with a fast recovery. So the question you might ask, am I a candidate for this procedure? And so if you qualify, these are the qualifications. We do this only for internal hemorrhoids, not external hemorrhoids. And if you say, well, I don't know which one I have, we can make an appointment and you can come in and I'll do an exam and I'll tell you which one you have. They need to be symptomatic, meaning they're bleeding. Bleeding is the big one. So that's really what we can treat. Sometimes discomfort, but mainly bleeding. And then we want people to try to do the easy things first, like the lifestyle changes, changing the diet. And, if you failed previous procedures, you can still come in. I don't think that's a prerequisite. You don't have to fail another procedure to come in. But if you have, we can still treat you. And then sometimes patients are told that they need a hemorrhoidectomy and they want to try anything they can to try to avoid that surgery. And this is a good option for that as well. You don't have to be super healthy to have this procedure. You can have heart disease, problems with breathing. We can accommodate that because we're not putting anyone under and it's not a stressful procedure. So we can treat patients that have kidney disease or pulmonary disease or heart disease. All those are acceptable. So what are the advantages? We talked about no general anesthesia, so that's not stressful to the heart. It doesn't actually, we're not strangulating anything, so there's no pain like in a rubber band ligation. We're not cutting. There's no risk of incontinence with this procedure. We can do this for patients on blood thinners because all we're doing is making one small puncture and then we close it with a device. So there's no issues there, and it is covered by insurance. All right. So if this is something that you think you might be interested in or you want to find out more information, you can schedule a consultation with us. You can use that QR code that's right there. If you take a picture of it with your phone, it will allow you to get to the website. Or if it's not working out, you can just go to ircenters.com and go to the Raleigh office. That will also get you there. And then what we'll do is if you schedule a consultation, we'll have you come in person. I'll say hello. We'll do a quick exam. I'll explain the procedure and answer any questions that you may have. I'm going to let you know if it's right for you or not. Okay. So that's my contact info in case you want to give us a call. Now, if there's any questions, I'll go and answer the questions. The first question says, can those microspheres and coils be removed if there are complications later? The answer is the coils potentially could, surgically. The microspheres cannot because they're too small. But I've never heard of anyone needing them to be removed. And I've done thousands of cases and I've never, I don't, technically they could, but I don't think they would ever need to be is my answer. Let's see. Also, any issues with MRI within the coils? There is no. The coils are made from platinum. It is a substance that does not create artifact on MRI. They're specifically made that way because they know that people who are getting these coils in may also have MRIs. And so these coils do not create any artifact on MRIs, so no issues there. How many years has this procedure been done in the industry? It's actually been done for quite some time. It started in France, actually. This is where they started doing a lot of the initial research was in France. And that was, when I say quite some time, maybe about 15 years ago. So it seems like a long time to me. I personally have been doing this now for about 8 years. So, but they've been doing it longer than that elsewhere. How do you handle a patient if they are on Eliquis? Can they just come off the blood thinner? So the answer is yes. If it's okay with the cardiologist, they can come off the blood thinner. But if it is too risky to come off the blood thinner, they can actually stay. You can actually stay on your blood thinner for this procedure. I often keep patients on their Eliquis for procedures if, for any reason, I'm at all worried about them coming off of it. If they've had a recent blood clot or they've had a stroke recently, any of those things, I will just keep them on the Eliquis. And there really is a low risk of bleeding afterwards, even though they're on Eliquis, because of the device that we use to close the hole in the artery afterwards. So either I would say come off for 2 days prior if you can, and you can go back on the next day, or don't come off at all if it's too risky. All right, any complications for type 1 diabetics? Now, the only thing with type 1 diabetics, if a patient has had an uncontrolled blood sugar for a good number of years, the arteries inside tend to be calcified. And so that potentially can make this procedure difficult or impossible if there's blockages. So if someone has had uncontrolled diabetes for a while, that can be problematic. If the diabetes has been controlled and blood sugars are pretty decent, then there shouldn't be a problem to do this procedure at all. If this works with one hemorrhoid and then a few years later you have another, is there an issue with having multiple over the years? No, there's not. We can do that, and that happens sometimes. I've seen that happen quite a few times in doing this. We'll treat the one hemorrhoid, patient will do well. Maybe a year and a half later, they come back and say, I have a different hemorrhoid that's popped up. Can we do this again? And the answer is yes. There's no issue with that. What are the reasons that patients require additional follow-up procedures? Yeah, so it's a good question. So the reason is because the main supply to the hemorrhoids is via the superior rectal arteries. That's what we kind of showed in that movie. Those are arteries that are coming down from above and supplying the very distal part of the rectum. On occasion, the hemorrhoids also get supplied by middle rectal arteries, which come off in a different location. Now, if we block the superior rectals, but we don't block the middle rectals, and they're a big supplier to the hemorrhoids, then the hemorrhoids may go away for a little while, but then come right back. And if that happens, we would just have to do that follow-up procedure. Now, a lot of times we look for the middle rectal arteries on the initial one to try to prevent that follow-up. And so sometimes that prevents it, but it's not perfect. So sometimes there's an additional artery that we didn't embolize the first time that needs to be embolized. And that's why people come back. All right, can multiple hemorrhoids be treated with the initial or own procedure? Yes, that is what we do. If you have multiple hemorrhoids, they can all be treated with one session, one procedure. Okay, I'm told I have 3 internal non-bleeding hemorrhoids that the surgeon wants to ban, requiring 4 visits. I'm promised there is no pain from that, but I read online that some people have a lot of pain. Am I a candidate for this? If I only have some discomfort and no bleeding, you gave me a very successful oh, good, I'm glad. Okay. Yeah, the answer is yes. So, requiring 4 visits, that seems, it's a lot. That's what it takes to do the banding. And I'm surprised they kind of tell people that there's no pain, because maybe that happens occasionally, but from what I've heard from patients, it tends to be painful. So are you a candidate for this? Yes, you are. So if you want to come and since you're already a veteran of our office, you know the drill. You can come and see me, and we'll just take a quick look, and then we can get you signed up for the procedure. Okay. How long is conservative treatment like diet and toilet change typically tried before doing the procedure? I think you want to give it a fair shot, maybe like 2 or 3 months of changing things if you can. After that period of time, if you're still having symptoms from your hemorrhoids, then that's when I would go and seek out a procedure, whether it's this or something else. But yeah, but my answer would be probably 3 months, around there. How do you do the consultation to know if I'm a good candidate? Yeah, so what we'll do is first, come in, you'll tell me what your symptoms are and what you've been experiencing and how long it's been going on. And then the exam, I'll have you we'll do an exam on the anus. So I'll have you take your pants and we'll get with some gloves and I'll look and just see what I see down there as far as hemorrhoids go. A lot of times people don't know if they have external or internal, so that's a good way to kind of check it out. And then just to understand, what's going on. The other thing we want to also look for is that a lot of times people have pain, but they don't realize the pain is from an anal fissure and not the hemorrhoids. An anal fissure is a little crack in the tissue there that comes off of the rectum and can be very painful. And so that's one thing I look for when I do the exam. I want to make sure that I see hemorrhoids, but I don't see an anal fissure as well, because the anal fissure obviously won't respond to this treatment. It's not the same. It doesn't get fed by blood or anything. All right, I've had the rubber band procedure several times over the past few years with very little success. This seems to be a good next step to consider. Yeah, I would agree. That's kind of who was initially described for this procedure as people who failed rubber band ligation. So yeah, I think that is true. I'd be interested. I wish we could hear you talk. I'd want to know if it was painful or not, because there seems to be some disagreement about that. What about external hemorrhoid treatment? Yeah, the problem is, so because the external hemorrhoids are on the skin, if we were to block the blood supply to those external hemorrhoids, we would actually starve the surrounding skin of blood as well, and that could cause sores. And so that's why we don't treat external hemorrhoids. So as far as external hemorrhoids, the treatments are the conservative therapies I've kind of mentioned earlier. So things like preparation H, or sitting in a sitz bath, topicals that you can apply to the area. That's kind of the mainstay of treatment for external hemorrhoids, as well as lifestyle changes, because those also are caused by the same type of things that cause the internal, like constipation, or doing a lot of pushing, lifting heavy things that can also cause external hemorrhoids. All right, short and sweet, right? Again, I apologize that we started a little late, but I'm grateful for everyone who stuck around and hopefully answered all your questions. Again, if you want to get a hold of us for a consultation, I can go back. Here's the QR code. If you want to take a picture of that, it'll take you to the website. Or you can just give us a call at this number and schedule an appointment. Now, I will tell you, our hours are somewhat, I guess, unusual. We're open from 7 a.m. until 3:30. So we're open. Mornings are great, but if you try to call us in the afternoon, you're probably going to get the machine, and I know that can be irritating. So give us a call in the morning, and we'll usually get you in for a consultation within a week or two, and we'll get that going for you. All right. So thank you very much, and hopefully, if this is something that's right for you, we'll see you in the office soon.